Hi, I'm Erin Garner. I'm the General Manager of Occupational Therapy at OT Australia, and I want to wish you all a very happy OT week. I hope you're doing something lovely to celebrate yourselves, your colleagues, and our wonderful profession. I also want to acknowledge the really tough times that we have all been living through over the past few years, be it the pandemic or natural disasters, which are continuing to impact our communities today. These situations take an enormous toll on us personally and also professionally. So I do want to say a big thank you to you all for your ongoing commitment to the profession, your practice, and working with your community so amazingly. I love being an OT and I love watching the contributions that you all make to the people you work with and the lives you change. Have a wonderful OT week and keep up the great work.
Hi everyone, my name's Karen Brown and I'm the Divisional Manager for New South Wales and ACT at Occupational Therapy Australia. I'm delighted to have the opportunity today to speak with Danielle Hitch about long COVID. Danielle is an occupational therapist with 25 years experience and has practiced in both Australia and the United Kingdom. She currently works as an allied health research and transition lead at Western Health in Melbourne and leads the Western Health COVID-19 Recovery Research Collaboration. Thank you, Danielle, for joining us. I'm really looking forward to having a conversation with you today and learning more about long COVID. So I suppose just to start, Danielle, I'm really keen to, learn a little bit more about long COVID and the definition for long COVID and some of the symptoms and how it manifests itself as a disease.
Yeah, for sure. Like a lot of things in the past almost 3 years, long COVID is new. We didn't really know much about long COVID until the second half of 2020. And long COVID's a really interesting case in consumer leadership because it was actually consumers who first identified long COVID and called it long COVID. So the first thing to know about long COVID is there's lots of different names for it. The World Health Organization calls it post-acute COVID syndrome. And post-acute COVID condition, post-COVID condition, like there's all sorts of, permutations of what it can be called. I think the best thing to call it is long COVID, just because that's the name that consumers come up with, but it's also just a bit easier and most people do understand what long COVID means. So when it comes to definitions of long COVID, it's important to note that there's no diagnostic criteria for long COVID yet. But there is a case definition which was also produced by the World Health Organization and came out in October last year. So they used a Delphi approach with lots of international experts to come up with a case description. And their case description says that to be considered to have long COVID, you need to be 3 months post your acute infection. You need to have sustained symptoms that have lasted 2 months or more. And those symptoms can't be explained by an existing condition or another condition. So long COVID really is a diagnosis of exclusion, which brings up lots and lots of challenges with that. The 3-month timeline is really interesting. In the UK, they use a 1-month timeline. So if you're still having sustained symptoms after 1 month, they would consider you to have long COVID. And the trajectories of recovery are really interesting because we know from our research that we've been doing here at Deakin and at Western Health that some people get a really good recovery after their acute phase and then get very sick after that. Some people slowly recover, so there's recovery happening, but it's very, very slow. And some people have a rematting, I'm going to start that again. Some people have a relapsing remitting course, so they have better and worse times. So the World Health Organization case description actually does allow for all those different trajectories. And the time frame is important really because occupational therapists are often all about early intervention. You want to get in as quickly as possible and get people to regain their function and get back to life. But oftentimes when it comes to services, those timelines are actually what determines when someone's eligible for the service. So if it's 3 months, then we have to kind of wait for 3 months for someone to get long COVID. And that's, potentially a bit of an issue. The other thing about just the definition is that under the World Health Organization case definition or case description, it can't be explained by another illness or another disability or concern that you've had. So while there's all these new people being diagnosed with long COVID, there's also another group of people who already had pre-existing conditions and they're not officially considered to have long COVID. So, for example, if you had diabetes previously and then you have an acute COVID infection and then your diabetic control gets worse, that's not considered long COVID. And I think a lot of people and a lot of occupational therapists assume that that would be classified as long COVID. But according to the World Health Organization, not at the moment, but these are people who still need additional support and healthcare services. And when it comes to the symptoms and, manifestations of long COVID, that's one of the real challenges. I think there is that classic post-viral presentation of people who get sort of brain fog, fatigue, breathlessness. But there's lots of evidence now that shows that long COVID can actually impact on any body system, any part of the body. So with the research we've been doing, we've had people mention things like hair loss, incontinence, really new and different allergic reactions, skin complaints, gastrointestinal complaints, everything. So there is a proportion of people who have that classic post-viral presentation, but not everybody will. And the other thing I would also say about that is that people talk about brain fog, relatively minor cognitive dysfunction. That can make a huge difference in someone's life, and that's certainly what our consumers have been saying, that it might only be that top 5% that's missing of function. So someone's made a pretty good recovery, but not a full recovery. But as time goes on, that top 5% becomes really important. If you, age and then you get cardiac disease or, other things happen in life. So there hasn't really been a discussion yet about optimising recovery, but that's a really important thing to think about. It's not really good enough for people to kind of be okay. And brain fog kind of sounds like something we probably all have first thing in the morning, but it actually is really debilitating for people, even though the cognitive deficit might be considered mild.
Okay, great. Thanks, Danielle. That's, I think, really helpful to set the scene around long COVID, and I think to start us thinking around a conversation around, I suppose, the role of OT within that space as well. I suppose just following on from that, I have read that you've talked about compounded disadvantage as well for people in particular who are experiencing long COVID. And I was just wondering whether you can perhaps just share some of your insights further into what you mean about compounded disadvantage.
Yeah, look, I think the pandemic has amplified disadvantage and also made, I think, the general population perhaps more aware of disadvantage and the impact that it has, not just during the pandemic, but on health and wellbeing altogether. So part of my role is working here at Western Health. We're in the western suburbs of Melbourne. We live in some of the lowest SES communities in Australia. It's a fantastic community, lots of diversity, fast growing, and it's a great place to work. But there is a lot of disadvantage in the local area. And I think it's really shown up in terms of case numbers and mortality from COVID, that our little area here has been one of the worst affected in the country. And we do know that if people are experiencing disadvantage, then they're going to have worse health outcomes for lots of reasons. So some of the examples that would be relevant to long COVID is that if you're in a low SES area, you're probably more likely to be in a job that takes you out of the home. You might be a truckie or an abattoir worker or something like that, which in itself increases your risk of COVID infection. A lot of the areas that have disadvantage also have quite high underlying rates of, kidney disease, cardiac disease, obesity, all of these things which can contribute to having a worse outcome from COVID. If you're living in a disadvantaged community, you might also not be able to access services at all or services very quickly. Not everyone locally has a GP around here because there aren't many GPs. So you're more likely to miss opportunities to get early intervention, and you might be sitting on a public waiting list for years before you get seen. And I think, it really showed up down here in Victoria anyway, the impact of culture in terms of communication and public messaging. So a lot of, and the COVID information was moving very quickly, especially in the first couple of years, but it's not always available in language. It's not always updated either. And so people can't get access to what they need to protect themselves from COVID infection in the first place. And they may not have access to information about what is long COVID. You know, these are the things you should be looking for. These are the times you should perhaps go and get some more support. So all of these things compound. It's, you know, intersectionality. You're not always one thing, you're multiple things in life. So I think the combination of the pandemic raising awareness about how much of a gap there is between sort of haves and have-nots, and you know what diversity does, has really shown people that this is a big part of long COVID. It's going to be a big part of long COVID for a long time. And I think the saying that I really enjoyed listening to people say was things like, oh, they're not members of the laptop class. So these are not people generally who can pick up their laptop, sit at the kitchen table and work. A lot of people have lost work during the pandemic. And the other contextual thing, obviously, is that, you know, the world economy is slowing down dramatically post-pandemic. So there's going to be even harder times ahead. So it's not to say that anyone who's quote unquote disadvantaged is automatically going to have a worse outcome, or, you know, is automatically a victim or anything like that. It's just an awareness that all these contextual factors play a role of how people respond to and recover from long COVID. And it's something that OTs are aware of, but the occupational justice aspect of it is a really good thing to keep in mind to make sure you're giving that consumer the best possible care you can.
Great, thanks, Danielle. I think that ties quite nicely into, I suppose, the next question when we're talking about consumers and talking about, I suppose, the impact of COVID or long COVID on our consumers is, I suppose, around the evidence. Obviously, as you mentioned in the introduction when you were explaining about long COVID, that there's not a lot of evidence there. It's an emerging evidence base just because COVID's only been around for a couple of years. So your focus of your research has really been around that consumer-led research and that. So really interested to hear a little bit more about your research and how it, I suppose, the focus it's taken from that consumer-led perspective, and how it's also led you to development of a model of care for long COVID.
Yeah, look, consumers are the experts at the moment. I mean, I would always say consumers are experts anyway, but they definitely are at the moment because there's so much we don't know about COVID in general, let alone long COVID. And as I said before, I think it's really interesting how this diagnosis, I suppose, of long COVID emerged from consumers saying, hold on, it's 3 months down the track, we're still not better, what's going on? And the first sort of research into long COVID was done by a consumer-led group that's online, and they're in America. So they actually did some citizen science and actually collected lots of information in the early stages, and they're still going now, about what are we experiencing, how is it impacting on our lives. And I think the really good thing about having such active consumer involvement in the long COVID space is that oftentimes the focus is on symptom profiles. You know, what are your symptoms? Are your symptoms getting better? Which is important, but not the functional profile of what that means in daily life. So having really engaged consumers make sure that focus on function isn't lost, and that is really important. I think it's interesting now that we're moving into a phase where we do know a little bit more, but not a hell of a lot more about long COVID. In particular, there's not a lot of Australian research. We're about to publish a qualitative analysis with 37 consumers, and we've now actually interviewed over 90 consumers, so we've got a big pile of data that we need to get into at some point. But the things that they really talked about was those trajectories of recovery that I talked about before. Return to work was really important, but I think we have to keep in mind that a lot of the people who step forward to take part in long COVID research are healthcare workers because they're at higher risk of catching COVID. And that's a very particular group. There's a lot of underrepresented groups in the research at the moment. But really they talked about getting back to my normal. So everything's changed in the last 3 years for everybody. And consumers aren't dumb. I mean, they were sort of saying it's not that I want to get back to 2019 and how I was then. So it's that contextual sort of thing of what's reasonable for me now, given that the world has changed, but also what is my normal. So, you know, if you have chronic asthma, it is your normal to have periods of breathlessness. So that's what you're looking to get back to. And that sort of stands in contrast, I think, to the more medical view or the healthcare worker view. We do this as well. It's not just medicine of I'm going to give you a standardised outcome measure, and if you come within the sort of normal average, then you're fine. It's not quite as simple as that. And there's no one measure for long COVID anyway. So at Western, as I've mentioned, we've interviewed a lot of consumers. Some of those consumers we've interviewed twice, 6 months apart. So that was good to get a sense of the trajectory of how people recover from long COVID. And generally speaking, people do get better, but for some people it's very, very slow. And the great wild card in all of this is reinfection. So in the first couple of years, the majority of people had, one COVID infection. I'm certainly aware of someone now who's had 5 COVID infections. The other wild card is, Wuhan strain versus Delta versus Omicron. And with Omicron, there's about, I think there's 10 subvariants of Omicron that are all very different. And another variant will come up, a more severe variant will come up. That's what happens with viruses. So all of a sudden, when you're thinking about what consumers are experiencing, you've got all these confounders of, well, how many times have they been infected? They may well have been infected, not known it, if they had an asymptomatic infection. Which combinations of strains have they been infected with? And that's why I think from the consumer perspective, it's been very clear of just get to know me and me as a person, because you can't really predict at this point what their course of recovery is going to be, what their symptom profile is going to be. We don't know anything really about what predicts people's symptom profile. So it goes back down to those basic principles that OTs always use. If, you meet with your consumer, you do a really good assessment and a really holistic assessment, and then you work with what you've got sitting in front of you, rather than, you've got rheumatoid arthritis, therefore we think we can do this, this and this for you. We just don't have that. But I don't think that's a bad thing. I think really that should be what we're doing with most people, is really sort of meeting people on an individual basis. So we did lots of interviews, we've done lots of surveys with consumers, and what became really clear is that consumers felt they weren't getting any rehabilitation or limited rehabilitation. So this was about a year ago. Mm-hmm. To be honest, that hasn't changed. There's still not a lot. There are some long COVID clinics if you were an inpatient during your acute COVID infection. But if you're out in the community, which is the majority of people, there's not much going on still. That may change because of the parliamentary inquiry that's currently going on for the federal government, but we'll keep our fingers crossed about that. But they were saying, we're not getting anything. We don't know where to go. We're not sure what to do. So from that, we co-produced a model of care called the Discovery Model. And a really unique feature, I think, of this is it's designed to be implemented anywhere. So it's not based on the more traditional models, which is bringing up around Australia of long COVID clinics. Some areas will have long COVID clinics because they have access to that expertise. But if you're in rural or remote Australia, or even if you live in the western suburbs of Melbourne, you may not have access to that highly specialised clinical model. And that's not to say those clinics are a bad thing. They're a really good thing. They'll become sort of centres of excellence for long COVID, so that's a good thing. And, if they have outreach as part of their model, that'd be great. And they can outreach to lots of different people. But realistically, not everyone's going to have access to a long COVID clinic. So the Discovery Model really focuses on care coordination. So there's 2 streams. One stream is for people who have significant disability post-long COVID. They go into an intensive rehabilitation stream. And in the model, the main thing they get is a dedicated care coordinator. So it's someone's job to really identify all of the different things they might need, put the package together, largely from existing services. I think what came through quite clearly too is consumers don't necessarily want some special service for them. They just need to go in amongst what's in their local community already. So people with significant disability move through that stream. Some will go to long COVID clinics, some won't. And then there's a self-managed stream, which is for pretty much everybody else. And we've developed, along with the consumers, an online sort of platform so people can go in and do their own assessment, essentially. And it starts with ADLs, then it talks about symptoms, And then it spits out at the end sort of the top 3 symptoms and the top 3 activities of daily living that you want to focus on. So that gives something for the consumer to take to their GP or whoever they're seeing to say these are the things that are important. And we prioritise them because a lot of these consumers have a lot of things going on and it's really overwhelming. At Western Health, we've also done some back-end work so that when that prioritised list comes out, we can also then give them a printout essentially of a personalised directory of services where you're saying you need help with this, this and this. Here's the things in the local area. Here's all their contact numbers. Off you go. So consumers are saying to us, a lot of us can actually follow this up ourselves. We don't need to wait. We just need to know what's out there. So I think that's the difference between the models of care, which tend to be for more people with more severe disability, which also need a lot of support and assistance, but leave out everybody else. And our model really caters for anyone who's got long COVID and has these 2 streams to give sort of slightly different approach to each. From an OT point of view, it's really founded in activities of daily living or occupations because that's what long COVID means. It's not really the symptoms, it's actually how it impacts on your life. So it is a very OT sort of way of looking at it, but it came from the consumers, not from me.
Excellent. Thanks, Danielle. That's really helpful to have those insights and really encouraging to see the model that's been developed from the consumers basically and from the consumers leading that process. So, yeah, really great to hear that. And I suppose as you've talked about, long COVID does have a huge impact on an individual's function, on their activity, on their participation, and that really is the focus rather than the symptoms that they have with long COVID. So I suppose I was just wondering whether you've got any suggestions, practical suggestions really, on the role of OT when it comes to working with people with long COVID.
Yeah, I think if you've got someone sitting in front of you with long COVID, I think it's really important to really listen to what they're saying. A lot of consumers report that they feel a bit gaslit by health professionals who say, oh, yes, everyone's tired or it's just post-viral. I'm sure all OTs are great at this, but, you sit down and really, really hear your consumer and all of the different things. I think you need to go in with a really open mind about what could be happening because the symptom and functional profiles are so varied. I think it's really important, obviously, you could do a really holistic assessment and a really comprehensive assessment with people, but it's really important to use outcome measures because what's going to help people move through their recovery, and it could be a very long recovery and a slow recovery, is having regular reassessment that shows them how far they've come. Especially if it's a slow recovery, it's really hard to sort of realise that actually 3 months ago I couldn't do this, but now I can. That also really helps with setting priorities and goals. So if you've got someone who's got a fairly slow recovery, you'll set goals obviously when you first work with them, but you need to readjust those goals. And if you're only focusing on the top 3 priorities, but there are others as well, once you've ticked those off, then you can move some of those others up into what you're working into. So I think it's, in a way, it's just OT 101 in a lot of ways of, how you actually work with people. In terms of assessments, there are a couple of long COVID specific functional assessments out there, but they weren't developed by OTs, and you can see that. I think, not that I'm saying they're bad, but they're not from our perspective of what function is. We've actually used the HUDOS 36, which is from the World Health Organization. 36 item 1 doesn't take that long to complete, but it actually gives you quite a lot of information about people's participation. There's also a 12-item version of it, which doesn't give you as much clinically, but can be good as a quick and dirty outcome measure. And we validated that with people with long COVID, so it is a valid tool to use for that population. And then I think it's about sort of looking at all the issues, what can we do? In terms of the evidence, there's not a lot of evidence of what works. I think what people have proceeded on is, use that post-viral thing as a template of what to do. So, graded return to activity, energy conservation, pacing, those sorts of things for the people with the classic sort of presentation. For people with non-classic presentation, I know there's some rehabilitation programs out there being developed for taste and smell. which is great. And that's probably one of the few good things that's come out of COVID, that area has now got rehabilitation programs set up for it. But it's also, I'd really encourage everyone to think outside of health, because long COVID can impact on, education, employment, cultural participation, all sorts of things. So it may not be that you have to provide occupational therapy from a health perspective, but you need to link people into other sectors because of the impact of their long COVID. Try and keep up with the research. At the moment, that's easy because there's not much around, but you will be able to, hopefully there'll be more sort of coming out very soon. A really good example of that is sort of graded exercise and graded activity. We know that for some people that works really well, and we know for some people that actually causes a relapse. And we don't necessarily know why. But I think there's a lot in the consumer literature and in the scientific literature too, that for some people, they'll go back to their clinicians and say, oh, I'm really struggling to keep sort of upping my activity. And of course, the clinician trying to do the right thing comes back and says, okay, just keep trying, push through it. And then they collapse essentially and they're back at square one. So that's an area, for example, where actually the evidence is really important. And that's not to say you should stop doing that, but just be really aware that that can also cause some problems for some consumers. So it's close monitoring, I guess. And I guess finally, I'd say, connect with communities of practice, connect with, the people who are working on the ground, because they're the ones who know the most about this at the moment, and really try and sort of build practice knowledge. In the absence of research knowledge, practice knowledge is more than good enough. I mean, that's usually what we're evaluating when we're doing research anyway. So try and connect and network as much as possible. There are networks springing up with OTs. So connect with those, because you'll get a lot sort of under the table grey literature from people, which is really helpful at this point. And we know that research isn't the only form of knowledge we use in practice. We use all sorts of things. So I think, the lag is going to be fairly long before we get a lot of research about OT and long COVID. So this is a good way to approach it in the meantime.
Great, thanks, Danielle. I think those practical suggestions are really helpful just to guide us as OTs of sort of, some of those next steps that we should be doing when we're working with those individuals with long COVID. So thank you. I suppose just from listening to some of the conversation today, and that it makes me think that we're obviously going to be probably experiencing the impact of long COVID for a very long time throughout our society, given the impact that long COVID has on an individual, as you said, whether it's health, education, work, etc. So I suppose just to close off the interview today, I'm just interested in your thoughts on how you think this may shape the work of OTs and the profession moving forward into the future when it comes to this area of practice around long COVID.
I think OTs can contribute on so many different levels, as always. I think, I've been starting to say to students and things, this will be with us until the end of our careers, no doubt. And we don't know the long-term impacts of COVID infection. We don't know if it's like polio, where it can come back, decades down the track and reactivate. We know from the Spanish flu 100 years ago, 100 and something years ago, that after large viral sort of outbreaks like this, the rates of Parkinson's shoots up through the roof, rates of dementia shoot up through the roof. So all of that's still to play out with COVID, and I hope that's not what happens. But it doesn't actually matter if you're in a COVID clinic or you're working with COVID patients. You are going to be impacted upon by the, long-term sequelae of COVID. So it'll be sort of ubiquitous. It'll be there no matter what condition the person has. It's probably been impacted at some point, if not by COVID infection, then by the experience of going through the pandemic. Down here in Victoria, lockdowns have had a huge impact on people's health and wellbeing. So it's not the sort of thing where, oh, we've got this new diagnosis and if I work in that area, I'll come across it. This will impact everybody. It does potentially provide more opportunities for the profession, because sadly there'll be more patients. This is, a new diagnosis. I think a lot of that will depend on how Australia decides to address long COVID. So we have lagged behind quite a lot up until now. And as I say, the Federal Parliament's looking at that at the moment. And depending on the models of care that are adopted, there could be much more opportunities for OTs in that space. In the UK, they're sort of further down the track than us, and they have long COVID clinics attached to their NHS. I know that OTs are part of those clinics, but from speaking to colleagues over there, it seems that their role's a little bit limited in terms of what they're asked to do, which comes back to the perception of, people have of our profession. We need to keep working on that. And I guess more broadly, I think, we've got some really good opportunities there to be allies with consumers. We're really good at that. And really push that consumer leadership and co-produce with consumers so that we end up with things like the discovery model that really reflect what the consumers need and want, rather than that top-down approach of, it's a specific condition, so let's set up a clinic. Like, as I say, that will work for some people, but not for everybody. And I really think there's a huge role for OT to get into advocacy and to get into the, driving the agenda rather than responding to it, because the sorts of things we can offer are the things that the consumers want. And we know that there's lots of good evidence to support what we do. So I think we just need to be, a bit more loud and proud about what we do and get out there, because that's definitely to the benefit of all those people with long COVID, some of whom, of course, will be OTs and have lived experience themselves.
Great, thanks, Danielle. Really appreciate your time today, and I think that's really helped to articulate, I suppose, setting the scene, one, of what long COVID is, but also the role that the important role that OT has to play when it comes to working with individuals with long COVID, and I suppose also the opportunities for the profession moving forward, both from a practical, clinical, service provision sense, as well as working with the consumers, as well as that advocacy perspective as well. So thank you very much for your time. Really appreciate you sharing your insights and thoughts with us today, and look forward to seeing your future research as you continue to work on that. So thanks very much, Danielle.
Thank you. I really appreciate it.